Hello. Today we will talk about tuberculosis. Again, not exactly the most favorite topic of the students, but believe me, tuberculosis is definitely the favorite topic for pathologists, especially older pathologists. They love tuberculosis. But don't take me wrong, tuberculosis is important. Even in those days, you will definitely see tuberculosis, the disease exists, and it's quite important. And moreover, since the tuberculosis is typical example of granulomatous inflammation, you can very easily and very nicely describe what granulomatous inflammation is generally on this specific disease. And that's why we start with the granulomas generally, because you cannot understand tuberculosis without understanding what granuloma and granulomatous inflammation is generally. So at the beginning, we will briefly describe granulomatous type of the inflammation generally, and then we will switch to tuberculosis. So granulomatous or specific inflammation. What does it mean? The word specific, it's quite old and not exactly not exact term, not exact description, because in the previous years or previous decades, better to say, in previous decades we knew just a few diseases that were associated with granulomatous type of the inflammation, just a few diseases that manifested granulomatous type of the inflammation. So in previous decades we were able to tie the specific disease with granulomatous inflammation. So if we saw granulomas in histology, we were usually able to tie it to specific disease, specific infection. So that's why we used to call it specific inflammation or specific type of the inflammation. But nowadays we know that there is a huge amount of diseases, both infectious and non-infectious, that can develop granulomatous type of the inflammation. So the disease is not specific anymore, but the specific inflammation is a synonym for granulomatous inflammation, and it's quite old term. And from the morphological point of the view, the granulomatous inflammation is a type of chronic inflammation. So it's a chronic inflammation, not acute. It's a chronic inflammation that is characterized by the presence of epithelioid granulomas. What does it mean? What the granuloma is? Granuloma, basically it's a collection of epithelioid macrophages. The granuloma develops if the macrophage cannot do its job, which means swallowing, engulfing, phagocytosis. If the macrophage cannot engulf something from various reasons, the macrophages literally join forces. They transform morphologically and they start to look like epithelial cells. That's why we call them epithelioid macrophages, which means that they look like epithelioid cells, but they are still macrophages. And they join forces and they create a collection, which we call granuloma. So granuloma, in fact, is a collection of epithelioid macrophages that join forces from some reason. And sometimes we can see also multinucleated macrophages, which means that the macrophages join forces even further and they created syncytium. Some diseases can develop necrosis in the center of the granulomas. Some diseases manifest granulomas without necrosis. So the presence of necrosis can aid us with the diagnosis. And on the periphery of the granuloma, there is a rim of lymphocytes. They are usually T helper ones and some plasma cells. So this part is the center of the granuloma with epithelioid macrophages, and this is the periphery with the lymphocytes. And basically we've got two types of granulomas. The first type is immune granuloma. This is the typical granuloma as we know it. So when we will talk about granulomas and nothing else, we usually mean the immune granulomas. So it has the morphology of a typical granuloma. And granulomatous inflammation, meaning immune granulomas, it's a type 4 hypersensitivity reaction. So it's immunopathological reaction of the delayed type. And the second one is foreign body granuloma. And it has nothing to do with the hypersensitivity. So that's why we call it non-immune granuloma. This is the type of the granuloma that can be found around stitches or around parasites of other foreign bodies. It basically means that the foreign body is so big that the macrophages cannot swallow it. So there is basically nothing wrong with the granulomas. There is nothing wrong with the macrophages. There is no intrinsic problem with the macrophages. They just cannot swallow the big foreign body. So that's why we call it non-immune or foreign body granulomas. And they look a little bit different. Usually there is no fully developed granulomas. There can be, but in a lot of instances there is no fully developed granuloma, and it's often just a cluster of multinucleated cells without fully developed granulomas. And then let's talk about the epithelioid macrophage itself. As I said, it's a transfer macrophage that looks like epithelial cell. That's why we call it epithelioid. But the transformation is not only morphological, it's functional as well, because those epithelial macrophages has, for example, decreased capacity of phagocytosis, there is a decreased expression of some receptors, contrariwise, there's increased secretory function, so the epithelial macrophage has enlarged Golgi apparatus and enlarged rough endoplasmatic reticulum and many other differences. And as I said, in some instances, the macrophages join forces and they create syncytium, multinucleated macrophage. So it's a fusion of macrophages. And we've got two basic types of multinucleated macrophages. The first one is a Langerhans type, and that is the multinucleated histiocyte that's usually found in immune granulomas. The cell is large, there are tens of nuclei, and they typically form a ring or something that looks like a horseshoe at the periphery of the cytoplasm. So this is the type of the multinucleated cell that's usually found in immune-mediated granulomas. So this is the type of the cell that you will find in tuberculosis, for example. And the foreign body multinucleated macrophage is a little bit different. The cell is a little bit smaller, and the nuclei don't form a ring, but they form a cluster in the center of the cell in the cytoplasm. And quite often there is a foreign material in the cytoplasm because the cell swallowed a part of some foreign material. So the giant cells, the multinucleated cells in foreign body granulomas look a little bit different from the giant cells in the center of immune granulomas. Why does this happen? I mentioned it on the beginning. From some reasons, the macrophage cannot fulfill its function, which means swallowing, phagocytosis, and subsequent lysosomal lysis. And because of that, the macrophages join forces, and they transform morphologically. They will start to look like epithelial cells. So they transform themselves into epithelioid macrophages, and they create a group which we called granuloma. And in some cases, they also create multinucleated forms. What are the causes? The material cannot be swallowed. This is the case for foreign body granulomas. So basically there is nothing wrong with the macrophages. They just cannot swallow the big foreign body. Some microorganisms are able to block the process of phagocytosis. Typical example is tuberculosis. We will talk about it later in next minutes. And TBC and many other infections, many other microorganisms have a various ways how to block the process of phagocytosis. So the macrophage cannot swallow the cell or cannot engulf it, and therefore they join forces. Sometimes the defect of the phagocytosis can be inborn. That's why a lot of primary immunodeficiencies develop granulomas. Typical example is chronic granulomatous disease, which is an inborn error of immunity, and presence of granulomas is typical for them because there is a defect of phagocytosis. And sometimes, again, there is nothing wrong with the macrophages, but they are stimulated by some other cell. So, for example, there can be long-term pathological stimulation, there can be overstimulation, but Th1 lymphocytes and the macrophages are driven to the hyperfunction. Probably this is one of the mechanisms how the Crohn's disease develops. And some diseases, some granulomatous diseases are idiopathic. We don't know what's the cause. Typical example, sarcoidosis. We are not sure what's the etiopathogenesis of sarcoidosis. So basically, the Th1 lymphocyte is stimulated by antigen presenting cells that present some sort of antigen to the Th1 lymphocyte, and the lymphocyte first it has some sort of capacity of autocrine stimulation by various cytokines, for example interleukin 2, and also and mainly the Th1 lymphocytes produce interferon gamma. And interferon gamma is the cytokine that stimulates macrophages. So the macrophage is stimulated, and the macrophage does multiple things. First, it is able to, as some sort of positive loop, it is able to stimulate the Th1 lymphocytes even more by production of various cytokines, for example interleukin 12. The macrophages also stimulate monocytes from the circulation by production of other various cytokines, and they also transform themselves into granuloma. So this is basically the pathogenesis of the granulomatous, so inflammation of the granulomas. And last but not least, please keep in mind one thing. This is rather a terminology, but there are two tissues or two lesions, or how to say it, specific and non-specific granulation tissue. Non-specific granulation tissue has nothing to do with granulomatous inflammation, and non-specific granulation tissue, that's something that all of you very well know, because that's basically a healing, the proliferative phase of non-specific inflammation. The non-specific granulation tissue is histologically is a loose edematous connective tissue, and if you have some sort of necrosis, for example, or any other type of damage, the lesion is replaced, it's cleared by macrophages, and then it's replaced by this granulation tissue, and the granulation tissue is subsequently replaced by scar, it transforms into scar. So non-specific granulation tissue, that's just a normal healing process of non-specific inflammation, or it doesn't necessarily need to be inflammation. The granulation tissue also replaces wounds, for example. So non-specific granulation tissue has nothing to do with the granulomas. Specific granulation tissue, on the other hand, that's a synonym for granulomatous type of the inflammation. So the specific granulation tissue, those are those granulomas with necrosis and with lymphocytes and everything else. As I said, the word specific is old term because in previous times we knew just a few granulomatous diseases and we were able to tie them or to link them to specific disease. So if you hear a word specific granulation tissue, that means all those granulomas and necrosis and all those other things that are component of granulomatous inflammation. But if you hear non-specific granulation tissue, it has nothing to do with granulomas, and it's just the healing phase of non-specific inflammation or some other sort of injury. You can see it here, as I said, non-specific granulation tissue, that's just the loose connective tissue with edema, some inflammatory cells, and high number of capillaries. So granulation tissue is a highly vascular and edematous loose connective tissue which will be subsequently replaced by scar. And specific granulation tissue, those are those granulomas with the necrosis, with the multinucleated cells and everything else. In practice, if you hear granulation tissue and nothing else, if you hear just the granulation tissue, we usually mean the non-specific one. So if someone says there is a granulation tissue and nothing else, the person usually means non-specific granulation tissue. And the morphology of granulomas can help us with the diagnosis. A few minutes later, I mentioned that there are some immune and non-immune granulomas, and even the morphology of the immune granulomas can be variable. If you see granulomas which are circumscribed, nice oval circumscribed granulomas without necrosis, there is no necrosis. If you see this in lungs or in pulmonary lymph nodes, it's usually sarcoidosis. If you see the same in bowel, it's usually Crohn's disease on the first place. So the first type of immunogranulomas, first morphological type of immunogranulomas is a granuloma without necrosis. Second type is granuloma with caseous necrosis. So there is a central caseous necrosis with the granuloma on the periphery, or with the epithelioid macrophages on the periphery, because the whole thing is granuloma. The macrophages usually form some sort of palisade around the necrosis. And if you see this, if you see granuloma with the central caseous necrosis, it's usually tuberculosis. So if you see this, regardless the localization, it's usually some sort of infection, tuberculosis on the first place. It can be something else, it can be syphilis for example, but you should always consider tuberculosis. The third type of immunogranuloma is a granuloma with central suppuration. So there is no caseous necrosis in the center, but instead of that, there is basically a small abscess. There is a pus in the center of the granuloma. So there is a small abscess with the epithelioid macrophages on the periphery. So we call this granuloma with the central suppuration or suppurative granuloma. And if you see this, it's usually bacterial infection. It can be mycosis, but usually it's a bacterial infection, and very often it's anthropozoonosis, tularemia, lymphadenitis mesenterialis, which means infection of Yersinia enterocolitica. It can be cat scourge disease and many others. So if you see this granuloma with a central suppuration, it's usually bacterial infection. And the last type is a granuloma with central fibrinoid necrosis. So there is no caseous necrosis, there is no suppuration, but there is a fibrinoid necrosis in the center of granuloma. You probably remember fibrinoid necrosis from vasculitis, but the fibrinoid necrosis can be also a component of granuloma. We call it necrobiotic granuloma. So basically, it's an immune-mediated reaction. Diseases that manifest necrobiotic granulomas, usually they are non-infective diseases, and they are some sort of immune-mediated process. So there is some immune-mediated necrosis of a fibrous tissue. That's the first thing, and the granulomatous reaction is usually secondary. So the first thing that happens here is the immune-mediated necrosis of the fibrous tissue, which has the appearance of fibrinoid necrosis. And subsequently, secondary, the granuloma forms on the periphery of the fibrinoid necrosis. So necrobiotic granuloma is immune-mediated necrosis of the fibrous tissue, which has the morphology of fibrinoid necrosis, with a granulomatous reaction on the periphery. And we call this necrobiotic granuloma. And if you see this, it's usually some sort of systemic rheumatic disease, such as rheumatic arthritis, rheumatic fever, and many others. It can be also seen in various immune-mediated skin diseases, such as granuloma annulare and many others. So if you see necrobiotic granuloma, it's usually some sort of immune-mediated non-infective process. And what is the fate of the granulomas? The granuloma can be healed by scar. So there is a fibrosis of the granuloma. In a lot of cases, the fibrosis, the scar that replaced granulomas, and it's typical for caseous granulomas, granulomas with caseous necrosis, so it's typical for tuberculosis. The fibrosis has a tendency to undergo hyalinization and then calcification. So the fibrosis, as a consequence of healing of tuberculosis, often calcify. And even the caseous necrosis itself can calcify. So the caseous necrosis can calcify, or the granuloma can be healed by scarring, and then the scar can calcify. And sometimes the caseous necrosis can undergo something like secondary liquefaction, and then the center becomes liquid. So it looks like a small abscess, which is not, it is not a true abscess, but it's a secondary liquefaction of the caseous necrosis, and the center of the granulomas is more liquid, more fluid. But the calcification is quite typical. So the calcifications in the lungs, especially in the previous times, often they were healed foci of tuberculosis. Okay, so now let's talk about the tuberculosis, because tuberculosis is the hallmark of granulomatous inflammation. And now we know what granuloma is, and we can move to tuberculosis itself. TBC is usually a respiratory infection, because the source of TBC, source of the infection, is usually another diseased patient with active TBC. So the infection is usually droplet, and the patients developed primary pulmonary TBC. But it's not a 100% rule, because you can develop, for example, primary TBC of GI tract by digestion, especially the cow's milk used to be dangerous in this situation. Or it can be percutaneous infection, especially as a professional disease among doctors and other professionals. But usually the TBC is a pulmonary infection as a primary source. The risk groups are usually basically all patients that are somehow compromised. Old persons, old patients. That's why we called it TBC of the elderly, because old patients that are polymorbid, they are a risk group of TBC, and it's often a primary disease, which is not so common, because in the next minutes I will tell you that the primary TBC is usually pediatric situation. But again, it's not 100% rule, but even the old persons which are polymorbid and somehow compromised can develop the primary TBC. We call it TBC of elderly as a term. Diabetic patients, because patients with diabetes, they are immunocompromised, because diabetic patients have impaired phagocytosis. So the diabetic patients are risk groups, or any other patients with some sort of immunodeficiency, acquired or congenital. Patients with other chronic pulmonary diseases are risk group for TBC infection, because the primary pulmonary disease serves as some sort of locus minoris resistentiae for TBC. Or the patients with slow socioeconomic status are also in risk of TBC infection from multiple reasons. So in fact, any compromised patient is a risk patient for TBC. I already mentioned that the mycobacterium is able to evade our immune system. That's why the granulomas are formed. And mycobacterium has a multiple ways how to evade our immune system. It can, for example, change pH in phagosomes, because as you probably know, each enzyme requires certain level of pH for the function. And it's the same for enzymes in lysosomes. So that the mycobacterium, the bacteria, can change the pH in phagosomes, and therefore it blocks the lysis in lysosomes. So the mycobacterium is engulfed, it's swallowed, but it cannot be digested. It also produces something called cord factor. Cord factor is a substance that can pathologically activate our immune response. TBC also produced lipoarabiomannan, which can block phagocytosis. So again, it can block phagocytosis, and it can also block oxidative burst. So the bacteria that are engulfed cannot be digested. It also facilitates TNF production, which can aggravate the tissue damage caused by the infection, and it can also magnify the systemic signs of the infection, such as fever, for example. It also produces urease that has other toxic effects. So you can see here that the mycobacterium has a lot of ways how to evade our immune system. How do we detect mycobacterium? Mycobacterium is acid-resistant, which means it's negative in gram stain. But fortunately, we have Thiel-Nielsen staining, and the mycobacteria can be visualized by Thiel-Nielsen staining. You can see it here, for example, or here. They look like violet rods or sticks. But nowadays, we usually detect TBC by PCR. And how TBC looks like? What is the morphology of TBC? As I said, it's a necrotizing granulomatous inflammation. So you will see multiple granulomas with caseous necrosis. And this sort of granulomatous TBC inflammation has three components. First is proliferative component. And proliferative component is basically the specific granulation tissue. So those are those granulomas with epithelioid macrophages and with lymphocytes and some sort of scarring on the periphery. So the proliferative component is basically the specific granulation tissue, it's the same. And then there is a caseous component, which is the caseous necrosis itself. As I said, sometimes it can undergo secondary liquefaction, but basically it's the caseous necrosis. So the TBC has a proliferative and caseous component. Proliferative is the granulation tissue itself, and the caseous component is the caseous necrosis in various proportions. And the third component is exudative. Even tuberculosis can create exudate. You probably know exudate as a typical component of exudative non-specific inflammation, but even the specific TBC inflammation can create exudate in case of serous surface involvement. So in case the TBC affects the serous surface, which is usually pleura or pericardium, it can form exudate. Rarely, it can produce exudate into alveoli. It's quite rare, but usually the exudate is formed into thoracic cavity. Histologically, the exudate has a serous fibrinous appearance, so there's a lot of fibrin, and it's often hemorrhagic. And it's good to keep in mind because if you see a patient with a hemorrhagic exudate, especially hemorrhagic pleural exudate, you should always consider two things. Well, first of all, you should exclude bleeding, that it's not just the blood, but it's hemorrhagic exudate. And if it is truly hemorrhagic exudate, you should always consider two things. First is TBC, and second, it's a carcinoma. Because the carcinosis, the spread of carcinoma on the pleural surface, it's often associated by hemorrhagic exudate. So always consider two things, cancer and TBC, if you have a patient with hemorrhagic, for example, pleural exudate. The TBC exudate also contains so-called ORT cells. An ORT cell, it is nothing else than the macrophage that engulfed mycobacteria. Such macrophage has a foamy cytoplasm because the cytoplasm is filled by bacteria, And if you stained this macrophage by Thiel-Nielsen, you would see small bacteria, small rods in the foamy cytoplasm. So the exudate in TBC is typically serous fibrinose, often hemorrhagic, and the Ort cells full of bacteria flow into exudate. And exudate has a tendency to be healed by very thick fibrous adhesions, and those fibrous adhesions often calcify. So at the end, the heart or lung can be literally cemented in a thick wall of calcium. So that's how tuberculosis looks like. Proliferative component, which is the granulomatous inflammation itself, the granulomas with epithelioid macrophages and multinucleated macrophages, and some lymphocytes and scarring at the periphery. Caseous component, which is the necrosis itself, and the exudation in case TBC affects some serous surface. There are two basic types of TBC, primary and secondary. Primary TBC means first TBC infection. So it's the first infection, and it used to be called TBC of children because usually the children were affected. But it is not the rule, not necessary. It's not necessarily just a pediatric infection. Even the older patients can develop primary TBC. So it's just the first TBC infection. Then there is a secondary or post-primary TBC infection, which means reactivation of healed TBC, or not exactly healed, but to say latent, dormant TBC, or reinfection, so another infection. Again, it used to be called TBC of adults because it usually developed in adult age, but again, it is not the rule. And then it's just short note, there is something which is called TBC on the virgin train. It used to be a TBC that was brought to distant lands, for example among Native Americans, because those distant populations have no immune background, because their ancestors didn't have TBC, so they had no immune background in their DNA, and therefore the infection had a very rapid and severe clinical course. And last is vaccinated terrain, because vaccination against TBC, it doesn't protect us from infection. It protects us from severe complications. So we can get TBC even in vaccinated state, but the TBC looks different. So as I said, usually it's a pulmonary infection. So there's an aspiration of the mycobacterium, usually right lung, because the right lung has a shorter and more wider bronchus. So it's usually right lung, inferior lobe. And so-called primary Ghon's complex develops there. What it is? What is a primary Ghon's complex? So when you aspirate a mycobacterium, a small focus of primary TBC infection develops. So it's a small focus of granulomatous pneumonia, usually 1 or 2 centimeters big. And then the infection is drained via lymphatics into the regional lymph node, usually the lymph node in the hilus of the lung. So you will have tuberculosis, lymphangitis, the inflammation of the lymphatic vessel, and then tuberculosis lymphadenitis. So the regional lymph node is full of epithelioid caseous granulomas. And those three things, primary TBC pneumonia, TBC lymphangitis, and TBC lymphadenitis, all those three things together, it's called primary Ghon's complex. So it's a primary infection of TBC. And what is the fate of Ghon's complex? The Ghon's complex can be completely healed. It's scarred, it often calcifies, and the lesion is healed. That's the first thing. Second fate, or second possibility, is a latent lesion, which means that the infection is stopped, but the mycobacterium survives and it can reactivate. So the lesion can be scarred or even calcified, but the mycobacterium survives and it can reactivate as a secondary TBC. And the third phase is progression, which we will discuss now. TBC has multiple ways of dissemination. First is local spread, but we will discuss local spread in secondary TBC because the local spread is not so typical for primary TBC, but it's more typical for secondary TBC. So we will discuss local spread in secondary TBC. For primary TBC, a lymphogenic or hematogenic spread is more typical. Lymphogenic spread means progression via lymphatic vessels into lymph nodes, and the nodes are enlarged and full of necrotic granulomas, which we call scrofullosis. It's usually a regional pulmonary lymph node, but any lymph node in our body can be affected. Especially in the older days, in previous times, it used to be cervical lymph node, and these nodes were enlarged and full of necrotic granulomas, and the lymph nodes could even open via skin on the surface, and then there was a fistula between lymph node and the outer surface, full of caseous tissue. So this was called scrofullosis. And hematogenic spread, it's a spread via bloodstream. It can be caused by direct invasion of TBC into blood vessels. That's the first option. Or it can be a continuation of the lymphatic dissemination. So the progression from lymphatic spread into the bloodstream. And the TBC is disseminated into distant organs. So the distant organs such as spleen, kidneys, brain, for example, they're affected by TBC, by granulomatous inflammation. And according to the size of the TBC nodules, we subclassify this disseminated TBC as a miliary TBC, large TBC nodules, and isolated TBC, so-called metastasis. It has nothing to do with the cancer, but we call it so-called TBC metastasis. Miliary dissemination is the most dangerous way of dissemination because it means that the target organ, the distant organ, is affected by multiple small nodules, small foci of granulomatous inflammation, approximately a few millimeters large, and it's very typical for lungs. So the patient develops a primary complex of Ghon, then the infection is disseminated into bloodstream, and then via bloodstream it goes back to the lungs. But the lungs are heavily affected by multiple nodules. Often the whole lung is affected by this miliary dissemination, and it leads to the rapid respiratory failure, and the patient develops sepsis. If the disease is less extensive, usually the apical parts of the lungs are affected. It's because the TBC is aerophilic. It likes parts of the lungs that are ventilated. So that's why the apical parts are usually the most affected. But as I said, in a lot of cases, the lung is affected in total, in a whole. This apical miliary TBC is called Simon's focus. So this was the miliary dissemination, which is very dangerous. Large TBC nodules, it means that in the distant organ you have one or several large foci of granulomas with a central necrosis. And the isolated TBC metastasis, it means that you've got one huge focus of TBC in some distant organ. Miliary TBC looks like this. This is the spleen with multiple small nodules of granulomatous inflammation. So it doesn't necessarily need to be lung. It can be any organ. You can see it in liver, for example. This is the liver tissue with multiple small granulomas. The problem is that such a small granulomas don't need to have necrosis, so it can be very tricky from diagnostic point of the view. What does it mean, miliary? Miliary, the word milium, it means this. It's a sort of oats, let's say. So it looks like those small oats. That's why we call it miliary TBC. And large TBC nodules looks like this. This is the kidney, and you see that the kidney is affected by multiple large foci of TBC with central caseous necrosis. So the whole kidney is affected by multiple large nodules. TBC can affect also bones. Usually a thoracic spine is affected, and very often there is no fever. The disease is chronic by definition, and usually the progression is slow and the symptoms are vague, non-specific, and there is no fever. That's why it used to be called cold abscess, but abscess in commas, because it's definitely not a true abscess, because abscess is purulent inflammation. So it's called cold abscess because there is no systemic sign of inflammation. There is no fever. And then necrotic tissue from the vertebrae, it could flow down into the small pelvis behind the psoas muscle. As a consequence, the thoracic spine was deformed. It was called malum poti, and those patients had a lot of breathing problems because the thoracic spine was deformed and the patient couldn't ventilate properly. And they were in a risk of secondary bacterial bronchopneumonia, which is quite important because a lot of those patients didn't die of TBC. They died of secondary bacterial bronchopneumonia as a consequence of impaired breathing. So it's good to keep in mind that often the TBC was not the problem, but the deformity was the problem. TBC can affect also skin. It's called lupus vulgaris, and macroscopically it looks like crusts and dry plaques on the skin that can be peeled off. Just a small historical note: a guy called Niels Finsen received a Nobel Prize in 1930 for this lesion because he found out that the skin TBC is very sensitive to phototherapy. The skin TBC used to be very common in those days, so that's why he got the Nobel Prize for this realization. And basilar meningitis, it's maybe the most dangerous complication of primary TBC. It's tuberculous meningitis. And basically, from the morphological point of the view, it's example of exudative form of TBC. It's called basilary because it usually affects the basal part of the brain, and it's extremely dangerous. It's a very dangerous complication, and not only because of the infection itself. There is also a risk of thrombosis of Willis circle arteries because on the base of the brain there is a Willis circuit. So the infection can affect also the arteries of Willis circle with subsequent thrombosis. So even the basilar meningitis can complicate itself by this problem. So basilar meningitis is very dangerous. So this was primary TBC. And as I said, the primary TBC has a tendency to disseminate into distant organs. On the other hand, secondary TBC is reinfection or reactivation of dormant primary infection. And as I said, miliary dissemination is not common because there is some sort of immune memory that modifies the way of the progression and that modifies the morphology of the disease. Immunocompromised patients are exceptions because they can develop miliary dissemination very easily, but usually miliary dissemination is not so typical for secondary TBC. We cannot rule it out, but it is not so common. Local progression is much more typical. So usually there's a reactivation of some dormant TBC. It's usually a lung focus, but it can appear everywhere. So you can have a reactivation of kidney tuberculosis, for example, but usually it's a lung. And as I said, typical is local progression. Sometimes it can reactivate in pulmonary lymph nodes, and then the lymph node is destroyed by granulomatous inflammation with the caseous necrosis. And sometimes the fistula was created between the lymph node and the bronchus. It's called adenobronchial fistula, and it was also another complication of secondary TBC. In the most of the cases, the apical pulmonary focus is reactivated. So usually it's reactivation of that Simon's focus, and it's called secondary apical pulmonary TBC or Eschhoff-Pools focus. It's the most common type, but you can appreciate any form of secondary pulmonary TBC. Any other focus of pulmonary TBC can reactivate. Sometimes you can see reactivation of focus that is a little bit lower behind or below the clavicle. It's called secondary infraclavicular TBC or Assmann's infiltrate. Or sometimes you can appreciate also the reactivation in the middle lobe of the right lung, which is called epituberculosis. But in the most of the cases, it's the apical TBC. And as I said many times, the local spread is the most typical. So the focus of granulomatous inflammation with the caseous necrosis continues to grow. If there is a more of the specific granulation tissue, so there is a lot of granulation tissue and small amount of necrosis, we call it tuberculoma because it forms one big node or one big focus that is yellowish, firm, and it may look like tumor. That's why we call it tuberculoma. If there is a more caseous necrosis, it's called cavernous form, and we will describe it in a minute. Tuberculoma, as I said, tuberculoma means that the focus of reactivated TBC has a large amount of specific granulation tissue and small amount of necrosis. And it's look like big whitish or yellowish focus or tumor, which is typically multi-layered. There are layers of specific granulation tissue that alternate with the layers of caseous necrosis. So the tuberculoma has a typically multi-layered appearance. Cavernous form is something different. Cavernous form means that you've got large focus of granulomatous inflammation with a huge amount of caseous necrosis in the center. And it can have a lot of complications. This focus can erode bronchus. And then the caseous tissue, the caseous necrotic tissue is cleared into the bronchus, and the patient starts to expectorate, cough out quite a large amount of necrotic tissue full of bacteria, and this patient is highly infective. It's called open TBC. Or this erosion of the bronchus is also a way of the porogenic spread via airways. So the TBC can spread on the surface of the bronchial mucosa. So that was the first thing, erosion of the bronchus. Second thing, this focus can open into the thoracic cavity, and the necrotic tissue clears out into the thoracic cavity, and again it's the way of the porogenic spread on the pleura. And the third complication is erosion of the large vessel, which leads to the bleeding. A lot of patients with open TBC cough out blood because of that. But one way or another, at the end, a cavern remains, which means that in the lung you've got an empty cavity where the caseous tissue used to be. It's called cavern. We've got several types of the cavern. We've got acute cavern, which has an irregular stellate shape with a central cavity, and the wall is formed by the residuum, the remnant of the necrotic tissue. That's acute cavern. And then the cavern is slowly healed, and it progresses into chronic cavern, which has an oval shape, and the wall is formed by fibrous tissue, which is basically a scar. So chronic cavern it's a scarred cavern. We can also subclassify the cavern into open and closed. Open means that there is some sort of communication with airways, thoracic cavity, or blood vessel. Or closed cavern means that there is no communication. It's just a cavity in the pulmonary parenchyma. Dangerous complication is a secondary mycotic infection, especially Aspergillus. Especially Aspergillus likes to colonize post-tuberculous cavern, which is called aspergilloma. You can see it here. This is the cavern filled with Aspergillus. And last but not least, we should briefly discuss TBC of the urogenital tract, because still we are talking about the secondary TBC, and TBC of the urogenital tract, it's the most common extrapulmonary localization, except for lymph nodes. Usually it's a reactivation of primary blood-borne infection. So usually there is some sort of dormant infection as a consequence of primary TBC, and this is the reactivation. The problem is, any part of the urogenital tract can be affected. And the problem is that the symptoms are often vague and non-specific. And in the urine, you can find leukocytes, which is called pyuria, but the urine is sterile to usual pathogens, usual bacteria. So it's called sterile pyuria. But in fact, it's a falsely negative sterile pyuria, because there is a mycobacterium. Okay, so that's all. It was tuberculosis. As I said, tuberculosis is a hated topic among the students, but the pathologists, especially the old pathologists, really like tuberculosis, and you should know it. And keep in mind that you cannot understand TBC without understanding the granulomatous inflammation itself. So I hope this was useful for you, and see you